Hi, my name's Lloyd Levine.
And my name is Rachel Strassman. And this is
Policy Chats.
Policy Chats is the official podcast of the School of Public Policy at the University of California, Riverside. Policy Chats is our student-produced podcast series where we bring in guests to discuss potential solutions to today's biggest societal challenges through the lens of public policy. While my classmates and I are the usual hosts,
for the next 11 weeks, I will be guest hosting a special series on the intersection of technology and government. This podcast series, sponsored by the Wall Street Journal Higher Education Fund, is based on my recent book, Technology versus Government: The Irresistible Force Meets the Immovable Object. This series explores different aspects of the challenges facing governments as they try to keep pace with the rapidly evolving technology landscape. We will try to understand why it is that government struggles to purchase and integrate modern technologies. We will explore the problems resulting from that technology lag and try to understand the future implications if government does not change its approach to technology integration. The episodes track with the sections and chapters in the book, with a focus on the problems, the people, and the future. Welcome back to Policy Chats. We're here today to talk about Chapter 5 in Technology versus Government: The Irresistible Force Meets the Immovable Object. I'm here with Chapter 5 with my co-author for Chapter 5, Professor Cara Chiaraluce from the University of Santa Clara. Really excited to talk to you. This chapter, as I was reviewing it in preparation for today, I think we did a really good job. I did not go back and cringe at what we did. This chapter is in the middle section of the book. We have the book's divided into three sections: the problems, the people. And that was very important to me because technology in a vacuum really doesn't do anything. The importance of technology is about the people it serves. So this chapter is positioned squarely in the middle of the book with an emphasis on the people, because that's essentially what it's about. So we discussed in this chapter the impact of the digital divide, or the lack of digital access, on the healthcare population. Why don't we start off by describing that? I don't want to, what we do with all these chapters, as we discussed prior, we want to make these a jumping off point, not a regurgitation of the chapter. But let's start off with a summary of the work. Why don't you kick it off? Talk about the chapter we wrote.
Sure. So, and I'm a sociologist, so the people, of course, are my focus. So that makes sense. And I think, this piece is really looking at how, really the lack of universal or, access to broadband internet access. So reliable, affordable, high quality broadband internet access is a significant determinant of health. And if we're talking about gaps and lack thereof, then we're talking about really health disparities and sort of issues in health and healthcare. And so this piece, I think, is very much born out of a lot of what we have learned in the pandemic, and where we saw very clearly that internet access is a prerequisite for healthcare. It's a prerequisite for access to healthcare knowledge, services, resources, connections, vaccines. We saw that very clearly with vaccine disparities. And so for that reason, I think, this piece is hoping to add to more emergent discussions of taking really seriously healthcare as a social determinant of health. So in sociology, we think of social determinants as the extra medical or the non-medical forces that determine health. And typically they're things like housing, diet, do you have safe working conditions? And so I think it's kind of bubbling up that internet now needs to be taken seriously in this realm of a really important, significant determinant of health. And so I think that's sort of the main kind of frame for this piece, and then getting into some of the, I think, very real world policy aspects. What policies exist? What sort of cases show us that, this can be done, or really kind of the efficacy of meaningful internet access, which is something that Lloyd, you coined, because it's not just talking about if we just give everyone access to broadband internet, all of a sudden, health outcomes for Americans are going to be better. It's much more complicated and nuanced than that. And so I think that's a large part of the argument here, right? Like thinking about what does meaningful internet access look like and how can we deliver that, distribute that to all Americans to improve American health across the board.
Yeah, no, agreed. And I, you're the sociologist, I'm the public policy person. And as a public policy person, for me, it's not about the policy, it's about the people as well. The policy is there to benefit the people. And you're right. The definition I created actually prior to the pandemic, meaningful internet access. It is internet access at broadband speed, but it's also a device. Access without a device doesn't do you any good. And then the other key component is digital literacy skills. And years ago, I've actually, worked for somebody who was a little bit older, and he had access and he had a device and he never used it because he didn't need to and he had no idea how to use it. And so that's a really key component. When we look at the data, and we discuss this in the chapter, the elderly population who may need a lot of these health services are also the largest component of the digital divide, along with lower income individuals. One of the things that we talk about in here that I find interesting, and I think let's, before we kind of jump off, want to hear your thoughts. I went to a conference, I don't remember what year it was, at the USC School of Medicine. I participated in a conference at the USC School of Medicine, and we discussed some of these same issues, and we touch on that a little bit in here. People think of internet access and the kind of the introduction to the chapter talks about that. When you talk about telemedicine, everybody thinks about futuristic movies and whiz-bang devices and all of these amazing things that they can do. But there's a whole other side that's actually far more impactful and far more real. And one of the things that I learned at this conference, because I certainly was not there as a medical expert, I was there as a broadband digital divide technology policy expert, was the impact on the one that always stuck with me, the health outcome impact on transportation challenged individuals. That's a real world today impact. That's not some sort of, step into this body scanner and, oh my God, look at all these things. If you are a transportation challenged low income individual, you're going to have a hard time getting to the hospital for follow-up appointments. And internet access and devices, can really be an impact. And we talk a little bit, why don't you talk about a little bit about what we suggest in the chapter to how to deal with that, which some people don't think about, but really could have an immediate and meaningful impact on health outcomes and not just health outcomes, but people's lives.
Sure. And I think, this idea of we know telemedicine exists, we have it, everyone can use it. I think there's a lot of sort of myths that surround it, or we think of medical technology in these really big, AI, robot type of ways. But I think this piece in particular is really thinking about how can we get healthcare services, resources, and care into people's homes, right? And that's the key piece, that the internet can do that. So the internet, can deliver these resources and get them into people's homes who otherwise experience really significant obstacles, one of which is transportation, right? Can you actually get to a clinic? Can you physically do that? Can you afford to do that? Do you have a car? Do you have access to public transportation? Can you pay for the gas to get there? I mean, these are really practical obstacles today that obstruct millions of Americans' ability to get access to preventative care, as well as, pressing healthcare sort of needs. The other piece is, I do work particularly with families and communities in the disability community. So autistic, neurodivergent children. And so for me, a lot of my research is in, someone thinks it's really easy or simple to take your child to the pediatrician or go to the ER. And for a lot of communities and populations, it's not that simple, parents that are caring for medically complex or fragile children, an ER visit can be really, really risky. And so again, I think there's a lot of very timely arguments for thinking about ways to maximize technology to bring it in homes, right? It can be family-centered care. It's safe. It's less risky in a lot of ways. It's more comfortable. And therefore you can also get better care, you know? And so I think, in terms of, again, like thinking about what that looks like, I think that was the second part of your question, Lloyd. Yes.
Yeah.
Something like that. I think what that looks like is
a question's just an opportunity to talk. I kind of wanted to tease out, kind of your thoughts on where this goes. And of course, I agree 100% with what you said. But to add on to that, there's other challenges. Distance, for example. I mean, you can look at lower income populations in urban settings that are transportation challenged. You can also look at rural challenges where, getting to the nearest clinic may be, 100+ mile drive. Or you look at low income working families where it's a burden just to get the time off of work. And if you could have at least an initial visit using technology while you're at the workplace, that might be another alternative option as well. But anyway, sorry, go back to what you were saying. Yes.
Yeah. And I do. I think one of the really kind of practical pieces of this too is that like that oftentimes like there's a gatekeeper there, right? That like HMOs, the sort of insurance processes are putting up gatekeepers that really could be highly sort of easily and readily alleviated with a telemedicine call, and so that I think starts this cycle later, which you could sort of then allow preventative care and all these other pieces. But anyways, yeah, I think the other pieces to add to thinking about like where this can go and important things to just highlight too is that when we're talking about, again, meaningful internet access, what does this look like? What does this mean? Affordable broadband internet, devices, digital literacy. And then the other piece of this that I'd also like to just highlight is that all of this needs to be culturally competent. And I think that's a piece that sometimes is missing from discussions, right? That like, even if these things exist, even if they're taught, it doesn't mean that people actually use them or buy into them. And so, any of the digital literacy training, education processes, apps, all need to be done in multiple languages, right? They have to have some knowledge and understanding of traditional cultural practices. Health and healthcare is such a cultural practice that I think, taking seriously like culture as a part of really, meaningful internet access is really important today. Again, if we're going to think about like getting people to actually use it, buy into it, and then improve health. And I think this is kind of like a model, right? This is a model that's a part of, I think, a larger kind of paradigm shift too of how we think about like the relationship between technology and healthcare. Because I think, as you said, Lloyd, like we think telemedicine or like these really big grand like AI robot are the only paths and usage for sort of like healthcare innovation. And I think
the movie version. It's the movie version of telemedicine for the on the ground, 2024 reality of where telemedicine should be right now.
Right. And so, I mean, I think like a part of like thinking a little bit differently or like opening up our ideas of what is e-health, right? What is telemedicine is like, imagine if when you left the hospital for an operation, or whatever it is, and you walk out and you get scripts, you get prescriptions, you get referrals, you walk out with crutches or a cane or, whatever else it is. And imagine if you also got a device. Right? Like that's part of like the post-op care package. That's part of care, sort of a caregiving package when now you're the primary caregiver of an ill, or, a sick person. And now you walk out with actual like electronic devices and devices that have training programs on them, educational programs, access to the skills. Like a lot of times you actually caregivers, engage in skilled nursing. And they're not taught that, or they're given a 5-minute, like, this is what you need to do, when you're walking out of the hospital and you don't remember. And so you need to go on YouTube. I talk with a lot of parents who spend a lot of time really learning skilled nursing procedures, and, other kind of specified knowledge through YouTube. And so like having access to these things. And then, another piece of this as a sociologist that could be a part of, again, like, like a post-op or like a healthcare package via a device is community building. I think so much today that's a really vital healthcare resource that really matters in people's lives is having access to support networks. And oftentimes those are digital, right? They're online support networks. They're finding people that, are going through similar experiences. And it doesn't require going anywhere, right? You can do it from the convenience of your home. And so those are all parts of, I think, care that could be really kind of distributed or mediated through a device. And imagine if we could get that a part of really sort of like a post-op, care package.
Well, and that's funny. When I went back and reread the chapter, there was times where I could clearly tell who was writing, you or me. That was one I couldn't figure out which one of us wrote it, because I've been talking about that thing since that USC conference. The idea of, you get a prescription for the antibiotics, you get a prescription for the painkiller, and the doctor, in certain hospitals, or if you're dealing with Medi-Cal patients, is trained to ask, do you have a way to get back for your follow-up appointments?
Right.
Because that's an important question. You just follow up. Well, you got to follow up. Oh, okay. We take it for granted that somebody's going to be able to follow up. And they often don't. And then, as part of that, do you have internet access at home? And you're right, write a prescription, and you go downstairs to the pharmacy, although it would be the digital pharmacy, and you get iPad or some sort of computer device. The other thing that you didn't touch on that I think would be a best practice, and I know we're talking about some things that might have cost implications. On the other hand, what are the cost implications to somebody's health of not following up on these things? Is a digital navigator. Giving somebody a device, and even if it's a relatively simplified device and internet access, you talked about cultural competency, which started down that road. And in language is obviously very important, in California with 100 plus, first languages spoken here. But a digital navigator, just the same way as you consult with a pharmacist who helps you understand how to take the medicine. Here's how you use this iPad, or here's how you use this computer to connect to us, show them. And there's actually a model for this. There's a project right now in Washington, the state of Washington, with the Washington Department of Veterans Affairs. There's a solution that they're using called CPR3, which is very much what we've talked about, connecting people to resources. And there, the veterans are actually given a device to utilize to connect to the Department of Veterans Affairs. And it recognizes all of the things that we talked about. There's actually 1,700 veterans in Washington with a customized device that has a customized set of apps for it. So instead of Facebook and Google, it's got Veterans Home, Claims Assistant, Traumatic Brain Injury, just to name a few of the apps. But when they're given it, it's not like, here you go, good luck. They actually sit down and they meet with a digital navigator to go over exactly how to utilize the device. And I think that's a great model to study. The program's been in effect for about 2 years now, and it's a great model to study to see how these devices can transform people's lives. Are we reducing costs on the back end by reducing visits to emergency rooms, reducing other cost barriers? So I think that's a great model. So, with that, let's use this as a jumping off point here. So one of the things that we talk about in chapter 4 is there's two sets of data because I co-authored chapter 4 as well. And there's two sets of data that I brought to bear there. U.S. Census data, which shows the uptake rates on government services. And then there's data from the Pew Center and the California Emerging Technology Fund, which shows the digital divide both currently and over time. And what you see is when you look at the digital divide, the people who are most likely to lack some sort of meaningful internet access are also the people who are most likely to utilize government services on a regular basis. So, we hear a lot of talk about eGovernment. So let's shift from eHealth as a specific example to maybe a little bit bigger conversation about eGovernment. As governments are shifting, rightly so, to eGovernment. Everybody is, the world is shifting from malls to e-commerce, newspapers to e-publications, and we can save for another day all the implications there. But, government is shifting as well to e-government services. But right now, the people who utilize them are people like you and me. And what do? Well, I renew my driver's license. I renew my car registration. I pay my fast pass for the tolls. And that's really on auto pay, so there's very limited engagement there. I filed my taxes. And so my engagement with e-government services is very limited. But if you look at the compendium of services that California has, and I've said this for a while now, and it's not just California. California does an amazing job of creating assistance programs for people with who are vulnerable, low income individuals, people who need assistance. What California and most states don't do is a great job of connecting those people to those programs. There's all sorts of those programs, from nutrition and food assistance to utilities, food, water, electricity, natural gas, to many, many others. And really, just candidly, it's a nightmare. And I'm guilty as the next, as a former legislator here in California, of not realizing this when I had the opportunity to do something about it. But as a low income individual, you've got to, call this person, call that person to get all these benefits. And the website, engagement is no better. eGovernment currently, the benefits accrue to wealthier individuals. As we go forward, how do you see the implications of what you've written here, maybe more expansively, not just for somebody, not as a super social determinant of health, but for other implications, from food resources to, low income assistance to anything else? How do you transfer the knowledge that we've gained here to others, to other areas?
Sure. And I think, the first point is all of these sort of forces, all of the problems, they're all interconnected.
Right.
Health is interconnected to social class. The wealth health gradient is almost a direct correlation, which is connected to food and housing policy and technology. And so I think first, they're deeply interconnected. And I think also they all, especially in terms of getting resources to the people and communities that need them the most, whether we're talking about healthcare or we're talking about nutrition or affordable housing. I think, Lloyd, you've hit on the key issue that hits across the board in all of these spheres, which is really delivery, right? It's this connection point to we have these services. They're even the best services. They're amazing services that can really help you and change your life, but if you can't get that service, right, or that resource to the people that need it, then the point is moot, right? And so this idea of the connecting people to services, or this linkage piece, I think is the same across any of these topics or spheres or populations too, And so then I think as a sociologist, then I think a way to begin to maybe, address this sort of key issue that cuts across is, especially in terms of, we're talking about technology here, right? How can technology be used to ameliorate, or again, try to chip away at this key obstruction, this disconnect between resource and population? So how can we use technology better to deliver, right? To distribute resources. And at the same time, I think it really takes a lot of on the ground getting into communities to do that work, right? Getting into communities, going to people's works, their schools, places that are relevant to their lives, in order to get people, again, to kind of get on board, right? To use the services.
The late adopters. You're talking about, getting people. Yeah.
And the same thing with any e-government, if you're trying to sort of boost, make sort of e-government, any processes more dense. I think it would take going into local communities, right?
What I've argued in speeches recently is we're creating almost a digital caste system, where you have where if you're lower income, you've got to go to the brick and mortar. And if you're not, then you can engage digitally. But what are the implications to the populations? Obviously, it's a much higher barrier, as we discussed with healthcare, to utilize. You've got the drive time, you've got all of those different things that are challenged there. And then there's the cost to government. We're providing. Would it be cheaper for government, rhetorically, to provide digital access to low-income individuals than it would be to provide brick and mortar for those same individuals? Because we can't give devices to low-income people. No, but we can create entire buildings to serve them. Wouldn't it just be cheaper to give them a device?
Oh, well, one thing I was going to mention associated with that is trust. That's another thing that really came to mind with thinking about obstacles and limitations. And again, whether we're talking about healthcare or housing assistance or technology adoption, right? I think anything that's kind of framed and attached with government services has this additional like cultural block associated with like trust in government, trust in, you know, authority, those sort of things. And so like that's a part of, I think, thinking kind of in an interesting way about cultural competency associated with technology. Right. And thinking beyond just like language usage and delivery, but also considering like, you know, to get people to buy into using technology and government supported technology and devices and digital navigators, that's also going to take some like massaging, I think, you know? Yeah.
However, to interject here, is if you look at the historical data going back, so I was on the founding board of the California Emerging Technology Fund. It was the first entity in the entire country dedicated to focusing on closing the digital divide. It was created in 2005, and I was on the founding board. And one of the things that we decided to do was, the mission was to close the digital divide. We thought we should measure it. So we have done, and I'm not on the board, but I still say we because, you know, I was involved for so long. What they did was to survey, starting in 2005, maybe six, an annual survey, scientifically conducted survey to see where things are. And it was not just internet access, but one of the shifts that you saw over time back in 2005, 2006, people didn't know why they needed the internet. They didn't understand the internet. It's not for me, et cetera, et cetera. If you look at the data today, and I've talked about this, in other papers, the only reason across the board, for low-income populations that they don't have the internet is cost. What you can see is if you cross-reference the data from the different questions, is they know they're missing out on something, and they just can't afford it. And that's where public policy comes in. You approach it from a sociological perspective, and I approach it from a public policy perspective. Okay, then how do we, and my contention is in 2024, the internet's essential. I actually gave speeches a couple of years ago, including one at Santa Clara called "It's Not About the Cat Videos on YouTube Anymore." And so there was this perception for a while. Well, what do people need the internet for? Oh, cat videos. It's not about the cat videos on YouTube. It's about, the connecting to government services, and it's essential. The internet is essential for engagement in civic life, for employment. And this isn't just, Lloyd Levine's opinion. There's ample research, starting, with education on kids who do and don't have access to technology, the performance outcomes, the entrance into college, all sorts of metrics on where that falls down. So how do we get the internet access? And the one thing that I've seen was prior to the pandemic, a whole lot of us in this space were trying to get attention for the digital divide. We spent a lot of time and energy talking about exactly the same things that you and I are talking about today. And all of a sudden we have a pandemic, and suddenly everyone's like, oh my God, did you know there was a digital divide? And we're like, yeah, actually we did. In my own kid's school district spent 3 weeks. First thing they had to do was, provide internet access to people and then distribute 30,000 Chromebooks so that the kids could learn from home. And so I think, hopefully we're seeing a shift now, post-pandemic, to where there is an acknowledgement that it is an essential part of life. And we are seeing government stepping up to figure out how, on a continuing basis, we're going to ensure that, that people who need it have access to the internet. So I think, that's an important thing that came out of the change in circumstances post-pandemic, that we discuss in the paper that looks like on a go-forward basis.
Absolutely. And so if I could ask you, Lloyd, since you are the expert and experienced in the actual policy, the real world policy making, what would it take to scale up a program like what you described that's with the Veterans Department using digital navigators? Because that sounds like a really effective model that's addressing a lot of these holes and gaps that we're discussing throughout this kind of segment, with a lot of grand potentials. And so I'm wondering, from a very sort of real world, or maybe it's not real world, I don't know, perspective, what does scaling, it is, right? And what does, scaling up something like that look like? And maybe what are some of the major obstacles besides, of course, the obvious, which is cost?
Well, that's a great question. So my day job is working for T-Mobile. I head up T-Mobile's state government technology strategy, and this is part of that solution. I don't want to, this. I try to keep as the old McRib commercial, the hot side hot and the cold side cold. My UC Riverside affiliation, is one thing. This is an intersection between those two, and I wouldn't just talk about things T-Mobile does on a podcast like this, except this solution is really transformative. It's the first in the kind in the country. It's the first time I've seen it, and it actually does exactly what I was talking about for 3, 4, 5 years prior to even coming to T-Mobile. The good news is we're actually making really great progress. As I said, in Washington, we've got 1,700 veterans with this solution. The Washington Department of Social and Health Services is using it as well, with about 4,400 people with developmental disabilities using it, and some of the testimonials from that are very impactful. They're using it in Oregon. The Oregon Youth Authority is using CPR3 as a way to reduce the recidivism rate. One of the things that I learned in my conversation with the director of the Youth Authority in Oregon is that the number one reason kids go back into the system is not because they've reoffended, but they've missed an appointment. Well, that's a communications failure, not malfeasance. So the CPR3 device there gives them direct access to the court system, direct access to their probation officers, access to educational resources, access to employment resources. We've done the same type of project in Washington. In Iowa and Colorado with Afghan refugees, and that's where, and those phones actually come in language. So one of the nice features about this is, the solution is infinitely customizable to meet the needs of the end user. And it actually changed my thinking, I will say. I used to argue that a cell phone wasn't necessarily an appropriate solution. And I still agree. In this case, though, a cell phone or a tablet, with the way we've created the applications, is actually an excellent solution, because instead of saying to you, hey, we know you don't have internet access, but we're going to give it to you. Now go do a Google search and find all these amazing things. We curate it for you. In partnership. But T-Mobile doesn't curate it. T-Mobile implements it. The state curates it. I have no idea what a veteran in Washington would need. The Department of Veterans Affairs tells us what the resources are that are supposed to go on the phone, and then they utilize them. The drawback, which is really more a direct answer to your question. So the good news is, and I should add this one, we're also using this in the Chicago public school system, and they're reducing the rate of absenteeism. And so we're seeing a lot of amazing benefits around the country by utilizing this technology. The challenge is most of the implementation so far has been grant funding, achieved through grant funding. And that's the downside. Grant funding isn't a sustainable resource. The Oregon Youth Authority and it's a smaller scale project. There's only about 450 kids a year who come out of the Youth Authority. So that's a much, lower price tag, and they don't all come out at once. So it's a rolling basis. So, that's an easier amount to deal with. The phones are very affordable. The price is incredibly affordable. But it's still, when you're scaling to 4,400 people, it's still, a couple $1 million per year. And finding that is a challenge. So what does it take to, now that I kind of give you that background context, what does it take? It's going to take a policy shift and a mindset shift. And it'll take people like you and me to do some research and analysis on what are the avoided costs. That would be key. If you're providing a benefit to somebody who hasn't had it, and it costs roughly $30 a month. The Washington Department of Veterans Affairs, it's about $30 a month for the full kitting, the device, the service, everything out the door. So as you can see, that's very affordable. You're essentially talking, about $360 a year. So, okay, what are the avoided costs? One of the other interesting conversations I've had recently was with the director of the team in Nevada who's setting up their 988 system with the Social Services Emergency Network parallel to 911, for those of you who aren't familiar with that. One of the things she told me is that her caseworkers see 3 people a day, and the rest of the time they spend driving. So if, Cara's time to be seen is the 3rd Thursday of the month and you need help on the 1st Tuesday of the month, what do? Do you call 911? Do you go to the emergency room? What are the cost implications of your alternate service delivery? If we give you a device for $30, we pull the caseworkers back into the office. You could still go to a house if somebody needs you to, but now you're there to engage on a daily basis. Help refer people to the resources. You give them access to the resources 24/7. But what it's going to take is the ability of researchers and advocates to demonstrate to government decision makers that, that we can provide significant cost savings and better life outcomes by utilizing these services. The one thing that I think that, was addressed in the pandemic was a pre-pandemic notion. It was, oh, we can't give devices to people. They're just going to break them. They're going to lose them. They're going to end up on eBay. And for the most part, the pandemic, when we distributed computers to kids, that laid that to waste. The other thing that I've seen personally with some of these folks who are getting these devices, they cherish this. They don't have a device. So to them, this is a lifeline. They're not selling it. Also, just from a practical standpoint, we have mobile device management engaged, and they're not exactly iPhone 15s, so they're not really worth anything on the open market. And they can be turned off instantly. To go back to summarize, it's going to take the research and the advocacy to show that the alternate path is actually a better path than the status quo. Status quo in government has a huge weight. Everybody in government, we know that works. Nobody ever got fired for going with the status quo. We're advocating for a radically different path, a path that I, in my experience as a technologist and a government person, think is the correct path to go down. The good news is we've started down that path, and I think we can get the rest of the way there. I really appreciate that question. That was great. Thank you for that.
Oh, of course. Well, thank you for your comprehensive answer. And I think if nothing else,
some government officials listening to this who can reach out and be like, hey, what was that solution? We'd love to implement it. Because that's why I'm doing this. That's why I just, as a quick aside, I love my job at T-Mobile because it allows me to do the same things I did when I was in government. And that's really transformed government to improve people's lives. That's why I worked on this book, because I'm so passionate about this. And I really do. I'm doing this podcast to amplify the message in the book for just that reason. I want policymakers out there to call me and say, hey, what was that? We're really interested in that.
Yeah, absolutely. I mean, because that's the thing, I like this series, this book, because it is not just theoretical. I love talking about ideas and I love talking about theories and models, but, it really matters most when we're talking about issues that are directly relevant to people's lives. And if we have these established models and programs that are evidence-based that show us clearly, this works, and we're talking about this works in life-saving ways, then it's a very compelling and meaningful work to think about the application piece, And I think if nothing else, in sort of your discussion previously, Lloyd, about this kind of scaling up of the Digital Navigator program, I mean, without the comprehensive data yet, right? It's the potential to address and improve a variety of social problems. That's the key piece, right? This isn't just about health or healthcare disparities. We're talking about educational disparities. We're talking about drug recovery, access to housing. I mean, incarceration. That's so interesting. When you talk about recidivism, I think the potentials are really compelling there. And so, now it's just the research, right?
Yeah.
We need sort of more measurement and research and data to show exactly, right, that this is what can be done, and these are the costs that can be saved that are, economic and financial, and they're also lives. I mean, they're human lives when we're talking about these issues of, drug addiction and incarceration and, health disparities.
Or even just, like I was saying earlier, and I actually experienced something when I was with the California Emerging Technology Fund, and we were looking at ways to help bridge the digital divide, and to bring in a different paper I wrote. One of the ones I think is the most important paper I might have ever done, is showing that the old model, because prior to the pandemic, the model, I describe it in the paper as information-based outreach campaigns, where essentially we rely on the discounted rates that the companies are providing, and then we send people into the field to tell you about this amazingly discounted rate. Well, when you looked at the data, and the effectiveness rate of that, it really wasn't working. Telling low-income people about technology, they either can't afford it or they perceive that they can't afford it. And so, I always joke, it's like me telling you about the $50 million yacht, but telling you, don't worry about it. It's 75% off. And you're like, yeah, 50 million, 12 million, whatever, right? It doesn't matter, and when you look at the income levels, some of these folks are so low on the socioeconomic scale that even the discounted rates are just out of their means, which is why I think there's a role for government to come in and not just look at the kind of the minute focus of getting them internet access, but the total picture of, as I said earlier, connecting the people to the full compendium of resources, all of these programs that we've created. So what do we do now? Well, they struggle and float along, but if we can connect them to the resources more meaningfully, do we address hunger? Do we address, does that hunger issue address, education? Technology and education is one thing, but hunger and education is something else. And if you can pull that all together, I think that's where the future needs to go. And it's just a matter of how do we get there? How do we get from the idea of e-government to the reality of what e-government should be, to the notion of, well, how can we provide iPhones to individuals, to recognizing that providing lower cost, not an iPhone 15, but lower cost devices to individuals actually saves the government money and improves outcomes. Like that's the $1 million question in the room, as to how do you get there? And so I'm happy to work with you on any papers you want to do, relating to kind of looking at CPR3 and looking to that as the key to providing these connections. I think there's potential, looking at this and going, what's next? Well, we talk theoretically about these devices, but has anybody gone to an emergency room? Has anybody done any conversations with doctors about, what is, we talk, you said theoretically, and I like to talk theoretically as well, but also practically. We sit around at a big table, at USC, and we talk about these things. And we talk about the implications to low income individuals about not having that ability to, but what is the data behind that? How many low income individuals are we talking about on a regular basis? How many people are not going to their post-operative follow-ups because it's a barrier? How many people, are we seeing here? And what would the cost implications of that be if you take a second population of people who had the same surgeries but then went through the follow-ups? What is the healthcare system spending on the people who aren't? You miss your follow-up, then what happens? Versus the people who are, like, is that okay? You had the surgery, you did the follow-up, now you're fine. You had the surgery, you didn't do the follow-up, now there's additional complications which are now requiring follow-up surgeries. I think there's room there for interesting research, both empirical research and just qualitative research, conversations with providers in these hospitals.
Absolutely. I know. And as a qualitative researcher, all of these ideas are being piqued, but you're totally right. Like, I can envision these projects that are being done in ERs where people are going and using the ER as first line care, which is so incredibly costly for various different parties involved, and, thinking about, again, like on the ground, what are the... Yeah.
I looked it up. In America, it is anywhere between, I think it varies state to state, anywhere between $1,200 and $2,200 to walk into an emergency room and be seen.
Right. And then we wonder why the U.S. has the most expensive healthcare system out of any wealthy, democratic, industrialized nation. I mean, well, this is one part of it. Anyways, but it's a part of this larger discussion and argument about cost, right? And thinking about how can we mitigate and, deal with costs in different ways. And to add to this idea of where do we go, or how could this be expanded or extended? I think something that's so incredibly timely and important right now is maternal healthcare is in crisis in our country right now. There are labor and delivery units are being cut left and right in hospitals, leaving, I believe one of the latest figures from the March of Dimes did a study, and Politico published it last year. Over 5 million women do not have access to OBGYN care. I mean, and that, I'm not saying that technology can deliver babies, but what it can do is it can provide prenatal care, and it can provide postpartum care, at least a large part of that is, I think, increasingly really in a crisis state in this country, that, again, like telemedicine and, e-health could help to fill some of those gaps.
Well, and I think myself, I'm not maternal, obviously, but I just think about a recent experience. I just had a severe case of acute bronchitis, knocked me out for a while. I mean, really bad. To the point where I was wondering if I had pneumonia. So I needed to get into the emergency room. So the first thing I did was I went on my phone, I went on my healthcare provider's app, and I was able to search and find a walk-in clinic. They referred me to the emergency room. A couple of days later, I still wasn't better. I was running out of medication. So again, I went to the app and I was able to schedule an appointment, and I was able to see through the app where all the clinics were. And I was able to schedule an appointment at urgent care and conduct all the follow-up. My tests arrived to show that I don't have the flu, I don't have this, I don't have pneumonia. If you don't have access to that or the skills to use it, you're going to directly to the ER first, or you're not going to the ER and waiting till it becomes an even bigger crisis. And then B, you're not able to really take charge of your own healthcare. And so I think there's so many ways with just even preventative care that the ability to engage digitally is so important. So, now that we've brought this back around full circle, we started with healthcare. We've kind of come back to healthcare, and we're coming towards the top of the hour here. Where I stand on what's next. Clearly what's next for me is to increase the distribution of CPR3, to help governments understand how CPR3 can address the issues, not just of health disparities, but really when robustly implemented, this device or a tablet can really be the one-stop shop. And actually, it's kind of funny. I use that phrase. After when I was, with CETF, we did this whole project, and I was, working with everybody, kind of realized how many different phone numbers you have to call. As I said earlier, you got to call this and that and this and that, discount car insurance and discount, all of these different things. And it's a nightmare. Especially, even digitally, it's a nightmare to go through all these things. And I joke that if I ever went back into government service, it would likely be, working for, a governor somewhere. Probably I'm not going to, run for office again. I would create the California Department of low income assistance. Instead of having all of these different departments, essentially the idea of one phone number, one website, you call them. And there's actually a model for this. It's really interesting. I learned this as well, when I was with CETF. But instead of making you call all of these different entities, call one. The other entities can still administer the program. But, instead of having to fill out 15 or 20 or 30 different applications, which 90% of the information is the same, let's just go to one. And the model for this actually is 311 San Diego, where they, 211 San Diego. I'm drawing a blank. It's 211. Anyway, the idea is they are that de facto county agency. They administer programs. They have referral agencies. So you call in and they'll open a case and they'll help you with all of the assistance programs that you're eligible for. And it streamlines the process and it assures continuity. So if you call again, they've got the same information about you again, and it assures you're getting access to all of the benefits. The state should be doing that. And for me, I think one of the layer on from where I was before to where I am now is that should be taking place through some sort of tablet-based solution, phone-based solution. So instead of having to travel to wherever, the apps are there for you. You can digitally engage. You can digitally engage with the customer service, quote unquote, customer service rep, somebody who can help you engage. That's where I'm going. That's where I see this going. That's where I'm taking this, part of this as I look at what needs to happen specifically in the realm of e-government. And I think T-Mobile can be part of that with our digital CPR3 solution. But I also I really want to educate government to really, I don't want us to have to push it on government. Government should be looking at this going, yeah, this is the way we do need to deliver e-government services in 2024, 2025 and beyond. And so for me, what's next for you? Where do you see taking your research? I'm going to ask you a 3-part question. So 1, what's next for you? Where do you go? 2, if you had a message for other researchers, what would it be? And 3, if you had a message for policymakers, what would it be?
Gotcha. All right. Well, first, I think very much in alignment with linking sort of what you mentioned, Lloyd, and then some of my kind of, adding to that with messages here is holistic, wraparound, coordinated care in any way possible, whether we're talking about healthcare, social services, for any groups, any particularly marginalized groups, is the gold star. Absolutely. And I think that's what you're talking about. At least that's what I hear in terms of having a centrally located, using technology, right, to kind of perform that key hub for wraparound coordinated care, which is really so incredibly important because I see in a lot of my work that so many of the problems and the limitations that families experience are due to fragmented care systems, whether we're talking about healthcare or education or, any other types of policies. It's the fragmentation that creates so many problems because no one's speaking to each other, and the systems aren't speaking to each other. And so then what happens is the burdens and the problems fall on individuals and their families. Right. So I think that's a big thing that I just want to highlight, that just sort of like, re-envisioning or just emphasizing like the need for wraparound, holistic, coordinated care, and that technology can be a really, really excellent and affordable way to do that is really important. And then secondly, in terms of like, where do we go in terms of like, I think research and policy? Yeah. I think, research, as we've mentioned, as we've discussed previously here, I think there needs to be, more research so that we can present evidence-based, compelling arguments about cost, because I think you probably know better. I mean, you know better than me that money talks when we talk about the people that have are in positions of power to actually like create these programs, right? To reform systems at the highest of levels. So if we can really document like, here's the sort of the money saved by using these more like e-health methods or these different models, then, perhaps we can get some movement, there. And we need good solid evidence to present that argument. And then the same, I think, thinking about change or like reform, I think of any type requires these two pieces, which is institutional and individual, right? The policy and the mindset pieces. And so I think there needs to be evidence on both sides. And then also like research and thinking about, well, how can we kind of better or start to change mindsets on technology, and in particular, like their potential to be used in any of these sort of health care realms, and as a potentially like really good, advantageous thing. And I think that's at both the individual and again, the systemic sort of, structural levels, because, if we reform these systems and we sort of use, like the digital navigator model, but we still can't get individuals to like buy in, and use it, then its efficacy is going to be limited. So I think, both research and, policy discussions and plannings need to take both of those pieces in mind, right? Thinking about like, how do we sort of reform systems? How can we deliver and distribute resources, and get resources to the people and communities that need them the most in the ways that they'll actually use them, right? That's the key piece. And you don't know that unless you actually have good, solid, qualitative research on the ground with the sort of communities and groups that you're seeking to serve, and really sort of creating policy, at least in my mind, by sort of using those voices. What do they need and how can we do that?
Yeah. So I agree. I think you've got to engage with the community groups and get out there. I think, one of the things that helps, and I co-authored a book chapter a year or so ago where we looked at new modalities. And one of the things is show people, instead of just telling them about something, bring devices, because, what you see is if people can see what they're missing out on, the shift goes from fear to, oh, I want that. And so I think that's a key component, and to engage with the community-based organizations who do have that trust. They want their people to be engaged, and they can help bridge. So I'm going to say, there's a program we have at Riverside, Science to Policy. It's a fantastic program at UC Riverside. It takes people who are getting their PhDs in other areas, and they get an additional certificate from the Science to Policy. It's a certificate program. I usually guest lecture every year, and one of my papers on connecting policy to research to policy is one of the assigned papers for the class. I'm going to give you an opportunity, now to not weasel out of the last question. You are an expert in e-health. What's your message to policymakers? What, if you're like, I need three things, or I will, if you had a chance to sit down with the governor, and say, I want three things, what would those three things, what would your message to the governor be?
Well, this is probably not as, I'll start off with a larger one, which is, I know what you're not wanting, Lloyd. But I think if I had a moment with a politician or a governor, I would be remiss if I didn't say that universal access to broadband internet is imperative.
Sure.
It's imperative because no matter what my other things that I'm going to ask for and how that's going to be delivered, like if I could get a moment and one thing, like that's how I would use my time. Because again, that is that key sort of linchpin for then thinking about all of these other sort of services and, social problems that we could potentially address and lives that could be really improved in a variety of ways. So that would be sort of my main thing. It's like, make it a political priority, right? A government priority to, again, prioritize universal access to broadband internet. And then I think a lot of sort of the other pieces would kind of fall into place. And then I guess the other piece of this is that I think, again, sort of emerging from the COVID-19 pandemic, I think health and mental health has also taken like a very more serious central focus. And e-health and telemedicine can serve really, really important means, not just for like healthcare or health-seeking services, but especially also mental health. And I think that's a piece that's sometimes missing, and it's so incredibly doable using digital technology. Like that's the thing. In a lot of ways, I think so many of our really pressing healthcare issues and crises in health and healthcare are actually so readily, we're able to sort of address them or mitigate them using technology. There just needs to be like the will, right? To do so. So I guess simply put, like all evidence shows us that we could make really great improvements on people's lives, health just being one facet, using digital access, and technologies when we just, need to do that, make it a priority, right?
Okay. I was expecting to hear
sorry, that's still probably
you got one more if you want. I was expecting number 2 was actually going to be something to do with the Medi-Cal reimbursement rate or the reimbursement rate for e-health versus in-person health as a way to shift. But maybe that's number 3 and I just stole your thunder.
Sure. I mean, I'd say yes. Okay. So I think, especially if we're talking about marginalized communities, right? Talking about sort of reimbursement. And also I think a lot of actual, like even insurance coverage of telemedicine or e-health has been sort of rolled back. Since sort of the pandemic has, sort of taken the back seat. And so I do think there needs to be sort of continual pressing discussion of the importance of these sort of insurance coverage or reimbursements, because I feel like it's starting to kind of be forgotten and sort of telemedicine coverage is being rolled back. Right. So maybe that's sort of an easy baby step to thinking about the bigger things. Yeah.
And kind of to bring it back to something I was saying earlier, that's the difference between the movie version and the reality. Mm-hmm. If we're going to recognize telemedicine, it can't be about, these fancy pods that do full body scans. It's got to be about the things that we talked about. And that's also got to be a funding source. The movies don't have to deal with reality of funding sources, in those practical aspects. I want to thank you very much, for joining us today. It's been a lovely conversation. I've really enjoyed it. I hope everybody who's listening found it as fascinating as I did and is inspired. And I want everybody to join me next time as we dive into Chapter 6 with Professor Deb Akit from the University of North Carolina. We're going to take a shift away from people as we transition to the third section of the book, and we're going to be looking at media's effect on policy. And really the, kind of the idea of as the internet has taken over, we've seen a degradation or even an elimination of newspapers. I just learned yesterday, actually, that last year, an average of 2.5 newspapers a day closed. The Los Angeles Times and the Washington Post, 2 very large, well-known papers, operated at huge multi-million-dollar deficits last year. What is the watchdog function? Where do we get the watchdog function on government? as technology has eliminated those institutions who used to provide that. And so Professor Akid is going to join me as we're going to explore all sorts of topics relating to technology, the media, and the interplay between technology, media, and government. Thank you very much again, Professor. Good to see you. Good to talk to you. Look forward to working with you in the future.
Thank you so much. Thank you for having me and for this very important conversation.
Appreciate it. For this episode and the entire Technology versus Government podcast series, special thank you to the UC Riverside School of Public Policy for their support. Thank you, too, to Dean Mark Long, whose support of this entire project was essential to its success. A special thank you to the executive producer and the usual host of Policy Chats, Rachel Strassman. Without her diligent hard work, none of this would be possible. Thank you, too, to the Wall Street Journal Higher Education Initiative for supporting the podcast and their effort to spread the word on higher education and technology in government. Thank you to the Policy Chats team of committee members who volunteered to support and produce the Policy Chat series. Divya Bharadwaj, Dinara Godegay, Derek Pedigo, Andrew Shannon, and Veer Sinha. Also, thank you to the team at the Hear Me Now recording studio for their excellent recordings of these podcasts. Jeff Holden, founder and principal, and Sawyer Malam, the technical director. And finally, thank you to Emerald Publishing for allowing me to publish this book that gave rise to the podcast series. Without those individuals, none of this would be possible, and they have my sincerest gratitude.
This podcast is a production of the UC Riverside School of Public Policy, and our theme music was produced by Veer Sinha. For the latest updates on the School of Public Policy, be sure to check us out at UCR_SPP on Instagram, or for more episodes and content, visit our YouTube channel. I'm Rachel Strassman. Till next time.